Hi, and welcome back to EEG Tutor. I'm your personal EEG tutor, Dr. J. Hayes McKay. Today we're going to talk about normal awake EEG in adults. You'll finally start to read EEG today, so buckle up. Here's a list of the topics I'll cover with you in this lecture of normal awake EEG in adults. The identification of common artifacts seen during the awake state will help orient you. We'll also cover this very important concept of the posterior dominant rhythm. This is the key of the awake EEG. The main principle I want to introduce to you during this lecture is know your normal EEG. Normal EEG is the anchor point when you're reading studies that will help you understand what you are seeing and will help you make sure that you do not overcall abnormalities. The dipole of the eye is an important concept I'll start with during this lecture. If you recall back to the first lecture, the dipole is a separation of charge. In the eye, the cornea is more positively charged than the retina. Here's a little schematic of that. This comes into play when you read an EEG because you're seeing the patient's eyes move quite frequently. When a patient closes their eyes, there's something called the Bell's phenomenon, where their eyes actually then tilt upwards. When you have this occur, the cornea is more positively charged, so you introduce a positive charge near to the frontal electrodes. This then causes what we talked about before when you have a more positive first electrode compared to the second, and that is a positive deflection, which is a downward deflection by convention. I'll show you some examples of that. Here you see it. You have a positive or downward deflection here. It's very much contained within the frontal electrodes. There's not much of a field. You don't see it at all by the time you get to these occipital or O2, O1 electrodes. This is common of vertical eye blink artifact. You see it with a very frontal predominant field that's really not how it would look if it was being produced by the brain itself. Just remember, it's very constrained to the FP1, F3 kind of electrodes. You see another example here. Here's a bit more of an extreme example of a lot of vertical eye blinks going on in this patient. Same concept though. You can see this very much a field that is contained to this front part of the EEG electrode array. It does not get into the back posterior part of the electrodes in terms of the field. Here's a similar example of vertical eye blink artifact, but then you see this is when the patient closes their eyes here, as we talked about in the previous examples. The thing I want to illustrate here is when a patient opens their eyes, you may see the reverse phenomenon, and that's here. That's when the dipole reorients and you have this more negative charge introduced here. We'll come back to this concept as we discuss reactivity as well, but that's a nice anchor point to start looking at awake EEG. When people are awake, you typically see this type of artifact. Okay, so here you have very rapid flutter. I wanted to just add this example because this can kind of confuse people. But when eye movements get rapid, you can start to really see them kind of looking like they're almost slowing down in the frontal region. But this is, again, completely contained to the frontal electrodes. Also, on this example, you have eye leads, where on these eye leads, when there's an eye movement, you should have phase reversals here, where you have a negative and a positive, and then a negative. This is what it looks like when you use eye leads. This is kind of an advanced concept. A lot of centers don't use these, but if your center does, I just wanted to say, hey, this is useful because you can tell it's an eye movement because you see time-synced eye phase reversals down here, negative, positive, negative, in the eye electrodes. This is something that you can use when you're not sure to see, hey, is this slowing or is this an eye movement? Horizontal eye movements use a similar kind of idea with this positive cornea compared to the negative retina. You'll have to forgive my illustration a little bit, But what I've done is try to show you how this plays out on the EEG. If a patient looks to the left, they're introducing a positive cornea closer to this F7 electrode with a more negative FP1. And this kind of the opposite here, where FP2 is more positive than F8. What this causes is you have a positive polarity discharge here at F7 and a negative polarity on the right at F8. And that's because F8 is more negative than the corresponding adjacent electrode you're comparing it to, whereas F7 is more positive than the corresponding adjacent electrodes you're comparing it to. So the positive polarity phase reversal is in the direction the patient is looking. So if you're looking at this patient, you're seeing this eye movement here. Which direction are they looking if the positive phase reversal is here in the left side? If you guess they're looking left, just like that example, you would be correct. Here again, you see a combination of vertical and horizontal eye movements in this recording. I want to draw your attention more to the horizontal eye movements. Notice them on how I switched a little bit here, where the temporal electrode chains are now down below. Which direction is this patient looking at this point in time where the cursor is? If you guessed left, you'd be correct again. And then, really just to kind of drive this home, you see the same exact phenomenon here. And to remember back, it's because that positive cornea is looking left here, okay? Here, I'll review the common EEG waveform frequencies with you. If you recall, delta frequencies are less than 4 Hertz. Theta frequencies are between 4 and 8 Hertz. Alpha frequencies are between 8 and 13 Hertz. And beta frequencies are greater than 13 Hertz. Hertz, again, are cycles per second, and each kind of block on the EEG is 1 second. This concept will play out in a moment, as the posterior dominant rhythm is typically in the alpha spectrum. So remember, the alpha rhythm in particular is 8 to 13 Hertz. The posterior dominant rhythm is one of the main concepts I want to introduce to you today. When a patient closes their eyes, their brain introduces an awake kind of resting visual state. And this resting visual state is picked up by the parieto-occipital electrodes most predominantly as an alpha frequency rhythm. And there's an anterior posterior gradient, meaning the amplitude and frequency are greater in the posterior electrodes compared to the anterior electrodes. In a normal patient, the amplitude is greater than 20 microvolts, and often you need to kind of identify eye blink artifact to confirm the patient is awake. One important concept is that it can be a normal variant for a patient to not have a well-defined posterior dominant rhythm in less than 10% of the normal population. The posterior dominant rhythm is something that has reactivity and occurs after eye blink artifact. We'll go through this very thoroughly. As of now, I just want you to see that there's an alpha rhythm here when a patient closes their eyes. If you count this frequency up, it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. This is an alpha rhythm that is the normal awake brain. You're going to see this in the normal awake resting visual state of the brain when the patient has their eyes closed most clearly. Here's another example of a well-formed alpha rhythm. Notice this concept of anterior to posterior gradient. You really see this alpha rhythm a lot better over the occipital electrodes than you do over the frontal electrodes. This is kind of an extreme example, but that concept's basically true in a normal alpha rhythm. The posterior dominant rhythm is important to differentiate from other rhythms by the alpha rhythm attenuating when eyes are open. So the patient opens their eyes, that visual resting state of the brain drops out, or it increases in amplitude conversely when the eyes are closed. So when a patient closes their eyes, the rhythm becomes more pronounced. When you see this combination, what you're witnessing is reactivity. A normal alpha rhythm A normal posterior dominant rhythm needs to show reactivity. Here's a great example of reactivity. The patient opens their eyes here. You're not really seeing much of an alpha rhythm or posterior dominant rhythm. Then they close their eyes here, and all of a sudden you start to really see a posterior dominant rhythm form. This is what reactivity looks like in a very pronounced example. On the flip side, here's a good example of when a patient opens their eyes and you see this alpha rhythm here that then attenuates or lessens in amplitude and it's not as well formed. This is also an example of reactivity. Here's another last example of reactivity where you're seeing this alpha rhythm, patient's eyes are closed, and they open their eyes and it kind of goes away. Now they're just blinking, but their eyes are open. This is what reactivity of the alpha rhythm or posterior dominant rhythm looks like. Now, when patients are awake, they may do things like talk. And so it's important to account for the dipole of the tongue. The tongue has a dipole that's the reverse of the eyeball. The tip of the tongue is more negative than the base. So what that really can lead to is kind of the opposite appearance. If a patient's tongue is pointing upward, it's going to lead to negative or upward deflection, sort of the reverse of the eyeball. And again, you name it based on the first electrode. So it's a negative deflection and it's going to point upward using our convention. Here's our Cartesian system to help you remember that. Often it presents as fluctuating delta. One way you can kind of ascertain if a patient has a prominent glossokinetic artifact or tongue movement artifact is to have them say la, la, la and see what happens. Here's a great example of that. And again, you see these negative deflections prominently here. Here's another example with a patient talking here, and you see glossokinetic artifact. It's important to identify this early in the study by having them perform this la, la, la test, because then when you see it later during the awake state, you'll make sure not to mistake it for slowing in the delta range and realize, hey, this is the patient talking. Equally important is your technologist being astute in marking this when a patient is talking or making prominent mouth movements with their tongue involved. Here's a bit more of a subtle example that I would not have been able to pick up without the tech pointing it out. You see they marked talking, and there's just some introduction of slower kind of frequencies in here with the patient making these tongue movements, glossokinetic artifact. Myogenic artifact or muscle artifact is also important to identify during wakefulness. Usually the patient is a bit more tense in terms of their facial muscles during the awake state than the asleep state. And you'll start to see this as just very dense kind of black short waveforms of high frequency which can obscure the tracing. Usually these are absent in the vertex region, so you may be able to see a bit more in that area. And you have to try to get the patient to relax or to sleep to get rid of this quite frequently. Here is an example here in these boxes of prominent myogenic artifact. And this is what it can look like. And you got to work with the patient to get them to stop talking, stop tensing up, make them relax. Here's another example of myogenic artifact. This black high frequency activity here is what myogenic artifact will look like. Notice that on this one you see myogenic artifact, but the patient's becoming more relaxed here, and you're not seeing it anymore. So this is kind of what you want to get at here. Another important normal variant in wakefulness that you should know is the mu rhythm. This is a sensory motor resting rhythm of the brain. It's usually about 1 hertz slower than the posterior dominant rhythm, and they're arch-shaped or archiform shaped waveforms. They're often maximal in a unilateral kind of central parietal region, but they can be bilateral as well. And you can block this rhythm by corresponding limb movements. So, if it's on the left, you can move the right limb and it will go away. Even thinking about movement of the corresponding limb will cause it to dissipate or attenuate. Here is a great example of a mu rhythm. See how it's kind of got this arched appearance, and it's really maximal more in the parietal region. This is what a mu rhythm will look like. Another example here. It's important not, it's kind of can look a little sharp at times and whatnot. It's important to not get worried about this being an abnormality. It's just another resting state, normal rhythm of the brain you'll commonly encounter. One of the last points I'll hit upon here is the concept of lambda waves. These are diphasic waves, really shaped like a lambda, that are associated with visual scanning. The highest amplitude is in the occipital electrodes. It has a positive polarity, which is an end-of-chain sharp waveform, for which you see a negative deflection in the occipital electrodes. And remember, that's an upward deflection in the occipital electrodes. You see this most commonly in childhood, but it's seen in a lot of adults as well. Here's an example where you see these waveforms. The patient's awake, vertical eye blink artifact, and you're having horizontal, a little bit of horizontal eye movements in here, and there's basically visual scanning of some type going on, and you see these lambda-shaped waveforms in the occipital region. Here's another example of this. You're seeing these lambda waveforms during wakefulness. This is a normal finding and nothing to worry about if you see this. Especially in younger adults, you'll see this very prominently, frequently. Okay, the final concept that we're really going to look at today is this concept of end-of-chain discharges. When you have a positive or negative polarity discharge in the occipital region beyond the last electrode, you start to have to use some imagination, okay? In this example here, I'm going to show you exactly why. So if you have a positive discharge here, you're only going to see this part really on the EEG, looking at these two electrodes. So what's going to happen is you're going to see more or less that the occipital part is more positively charged than the parietal part, okay? So when that happens, you actually get a negative deflection upwards because the parietal part is more negatively charged relatively than the occipital part. But what you're not seeing is that if you introduced another electrode here or over here too, that you're actually then this O2 region is actually the most positive, and it's positive relative to this other area. So there's actually a positive or downward deflection here. You're just not seeing it. You have to use your imagination because you're only seeing P4 versus O2 or this part here. So when that happens, when you can use your imagination, you could think of this as a positive polarity discharge. It just happens to be at the end of the chain. That's what a lambda wave is. And again, positive polarity discharges, you can put a plus sign there. To kind of hammer this home, we're going to look at these lambda waves, and I use that fictitious X electrode that we introduced on the slide before and made this mirror image, and this is what you would see if that electrode was there. You have the positive polarity discharge for the lambda waves. Remember this concept. This will also prove useful to better understand some findings of sleep, which we'll cover next lecture. Without any further ado, let's see what you remember from this lecture. If you close your eyes, is there a positive or a negative deflection in the frontal EEG leads? Which direction does the waveform go? Upward or downward? Take a minute, think it through. If you said that it's a positive deflection, but the waveform goes downward, then you would be correct. If you remember from our Cartesian system, when you close your eyes, that positive cornea is near those frontal electrodes. That makes those electrodes more positive relative to the other adjacent electrodes near them, and that causes the waveform to go downward in a typical AP bipolar montage. Okay, question 2. Which direction is the patient looking during the highlighted region here in this picture? Remember, it's a positive polarity here and a negative polarity here. If you remember correctly, the patient here is looking left because they are looking towards the direction of the positive polarity. Question 3. When is the alpha rhythm most pronounced? With the eyes open, during eye closure, or with mental concentration? If you said during eye closure, you'd be correct. Because if you remember, this is a visual system resting state, so you're going to see it best when the patient's eyes are closed. Here's an example again of that. Patient closes their eyes, vertical eye blink artifact, and all of a sudden you see that alpha rhythm. That's reactivity. Okay, here's some references of this, and I hope you enjoyed this lecture. Congratulations, you now know how to read normal awake EEG in adults. That's exciting, and it's a great foundation to continue to work from as we move on next lecture to normal asleep EEG in adults. I'll see you then. I'm your personal EEG tutor, Dr. Jake Hayes McKay.